removed. And then he said, well, my cover said, it's like a car. He had a cover, one of those ones from retirees, which says, diagnose, examine, and treat. And the man had a wart, which he had had all his life when he's 65, and said, this thing has been a bother to me. And he had it removed. But honestly, he didn't have to go all the way to India to have a wart removed. But I looked at it more like somebody who's 65 who was really enjoying a holiday, and whatever he was doing in this East African country could have been done. Now, I'd just like maybe our panelists, maybe just to introduce themselves very briefly for the audience, explain where you've come from, what you do, and your interests on being in this panel. And then I will come back to each of you with a round of questions. Thank you.
Thank you very much, moderator. Good evening, everyone. My name is Danny Mutembe. I'm coming from Rwanda, from the Rwanda Healthcare Federation. I have been the chair of the East Africa Healthcare Federation for 2 years, right before Dr. Ian. I am a pharmacist by profession. I'm interested in pharmaceuticals, and I basically deal in pharmaceuticals, and that's what I've been doing in my career. One thing that I'd like to mention is also that I'm second-generation pharmacist, and I hope that we'll also be talking about generations here for future generations. Thank you very much.
I'm Nazir Arab, Medical Director, Managing Director, Apollo Medical Center Limited. We have 2 institutes, one in Dar es Salaam, which is the commercial city, and one in Dodoma. I have been the member of various medical federations like East African Health Federation, African Health Federation. Have been on a panel of Pan-African medical tourism in South Africa, which started and died somehow by a natural death, I don't know. I'm very much keen on medical tourism because I'm involved in this since 1998, somewhere there, okay? My main interest on this is that how can we ethically control medical tourism and how can we optimize medical tourism within our own country? That's my interest. Thanks.
Thank you. My name is Francis Mwanis. I'm the Registrar of Private Health Facilities from the Ministry of Health in Tanzania. I have been a registrar almost for 3 years. And before that, I've been an administrator in different posts. I've been the district medical officer and the regional medical officer for quite some times. Actually, what I'm interested with the medical tourism, after realizing actually the money that the country is spending for referring patients in abroad, the service that can be offered within our East African continent. And my main interest is how best we can work to make medical tourism a success and optimize on it. Thank you very much.
Thank you. Good afternoon. My name is Dr. Mohammad Shakur. I'm from Ethiopia, internist and gastroenterologist by profession. And I am vice chairman of the Ethiopian Healthcare Federation for the last 4 years. My concern and worry is how can we prevent our people going abroad and taking our resource to abroad with this mega resource? How can we help our people be served in their country or neighboring countries? Thank you.
I'm Kirti, although the introduction was very formal, but let me tell you, I don't represent India here. I've come here as an expert. I do something called South-South capacity building and knowledge exchange, which means whatever is good in one country, how that can be given to another country so that they don't reinvent the wheel. And I've been doing it between Asian and African countries for last 15 years. I'll give you an example about Rwanda as a country. Rwanda was facing a big challenge. The people in Rwanda were not getting a pair of glasses at some point, 12, 15 years back. When I analyzed their list, Unfortunately, the glasses was in the cosmetic. It was a cosmetic product. It was a fancy product. So I said, you just bring it down to the essential product. And the customs will allow you to bring that in. And that changed the whole game. Now, today, probably Rwanda, glasses are available to every nook and corner of Rwanda. Pair of glasses, okay? And Rwanda is in the forefront. And I learned a lot from Rwanda by going to that country, how their referral system is so well designed. And I am advocating that back in India and other Asian countries. That's what I do. Thank you.
Thank you, Professor Pradhan. Since you have the microphone, one of the biggest problems we have in the region, which is not only affecting East Africa, but Sub-Saharan Africa, is the whole issue about skills. You can't develop medical tourism if you're not able, first of all, to train, you're not able to attract, and then retain the skilled healthcare workers. From your travels, how are we going to be able to do this? Because all our ratios, Kenya is more privileged, but all our neighboring countries, the ratios of doctors to the population, nurses to the population, and medical tourism, as we've seen, thrives on development of specialities. Very quickly, not in too much detail, give us, we leave this room, you can tell us, lobby for this, advocate for this, new governments, and be practical about this. How do we scale up essential skills?
Thank you, sir. The similar problem is there in most of the developing world. And let me give you statistics. India needs 6 million allied health workforce today. Now, they have only 1 million. And in a health system, let me explain you, it's not the doctor's role. India has 1 million doctors, allopathic doctors, modern medicine doctors.
Abroad, when COVID started, we had a former president who actually died. Not that there are only 3 ventilators in the whole country. So here are we dreaming when we talk about medical tourism? Well, there's more need for us to leave, particularly the elites, than to stay here.
Thank you very much. Actually, that's really a very important topic, and we're talking about the elites, but the leaders. I believe each one of us here in this room is a leader somewhere. If you're not a leader in a government position, you're at least a leader in your house. leadership encompasses decision making. And I think COVID was an instrument to show us that bad decisions lead to very dire consequences. Some of our leaders, including us, were traveling abroad to get treatment. When COVID came, they closed borders, so we had to deal with our own health systems, the health systems that we built or we didn't build. And that should be a wake-up call for all of us. We see how, and I'm happy that Professor talked about India, and I've been in India, and I was trained in India for 5 years. We saw how India grew, relentlessly, and we've seen how other countries have also improved different systems. We've seen our countries in Africa improving some of the basic things, infrastructures. But when it comes to investing into healthcare, you will see that even health professionals do not do that. You will see medical doctors, I'm sorry, I'm not targeting medical doctors per se, but they will be the best investors in real estate. Yes, you want to invest in something that you believe in. So you have to believe in your healthcare system. If you are a leader and you are a decision maker, you have to believe in that healthcare. If it's not for you, and I was talking about generations, you have to think about the other generations, what you're going to leave behind. I'm just going to give a quick example for Rwanda that Professor talked about, and the country I'm coming from. We look up to Kenya. We still look up to Kenya, and I'm talking about East Africa as a region. And one of the key decisions that the Rwandan government made when Rwanda joined the East Africa community is to change our time, not the time zone, but our time, our working time. Rwanda realized that once we were in office, we started at 8, like most of offices. Kenya was already trading for 1 hour. It was 9 here. So they moved the government offices time to 7. And by 7, everyone has to be in office and start working. So we really have to be proactive, and we really have to start setting our priorities right. If I came last week from Congo Kinshasa, that's the country I was born in, and it's a beautiful country. The healthcare system is close to non-existent. You have few hospitals, and they are run by foreigners, including Indians, and then they will travel. There were examples of them traveling to Uganda and other places. And this is one of the countries in Africa, if not in the world, that is the richest in terms of resources. And of course, the leadership will travel to any of these countries in Europe because some of them can afford it. But with COVID, it was not possible, and people suffered and they died. Congo Kinshasa this is one of the countries that has the largest numbers of churches. And please don't get me wrong, I'm a born and raised Christian, and some have other beliefs. I don't have a problem with praying. Pray, but do get treated. And for you to get treated, you have to have access to quality care, to quality health care. So you should think of how you're going to leverage on what others are doing. We should be thinking here on how we could leverage on what India is doing, for instance. We are leveraging on what Kenya is doing. Kenya is extremely good at writing down laws, drafting laws. Most of the East African laws are based on what the Kenyan law has done. What Rwanda is good at is at implementing. And sometimes we complain because we're like, but the people who draft these laws are a bit lenient. Can't you? But, in Rwanda it will be, it's either the right way or the wrong way. And we choose to go that way. And I think that's very important. There's a word I wanted a phrase that is in Latin that says, agi quod agis. Agi quod agis is simply do what you do and do it perfectly. If you're doing something, do it perfectly. If you are into the healthcare space, if you have a hospital, you have to look for the best. You have to go for these accreditations. You have to do the best. You don't do half-half. It does not work. And the last thing, and I think that was also alluded to by Professor, is advertising. When you do something right, you advertise it. You put it out there. People know. People get to know what you're doing. If you are hiding, if your things are not there in the internet, your tariffs are not clearly shown, this means that you still have a gap, and that's a big issue. I wanted to just say something about the pharmaceuticals.
You can't be last all the time.
No, that's now a bonus. The pharma, Africa is the place of counterfeited drug. This is a $1 billion business. So while we're sitting here trying to figure out how we are going to get ourselves out of this mess, out of this trouble, bringing back medical tourism to us, there are some other people who are working so hard to cripple our systems and make us slaves of other systems. So we have to figure out, we have to see this in a holistic way, include all the cogs of the machinery and move along together. But most importantly, like he said, transfer of appropriate technologies. Thank you.
Thank you. Dr. Arab, you're based in Tanzania, as it were. And I admired the growth of the Tanzanian private sector over the last decade or so. It was very dynamic compared to before. And I know you, a lot of that has been facilitated by your NSSF. My question to you is the bigger debate about universal healthcare. And at the end of all we're going to do, even if we say I have the best facilities, I've got the best trained people, how will all this be paid for? Given your experience handling in medical insurance and all, is mandatory health insurance the way to go? Or what are your thoughts? You must have given this quite some thought.
Thank you. Yes, Tanzania at the moment is leading in HIF that is taken up to about 26%, if I'm not wrong, up to 15, I'm quite sure, are being covered. But coming back to this UHC, I personally, with an experience of 45 years now in medical field, do very much feel that UHC is a failure. It has not worked in the developed countries. The only country which has benefited or which is practicing this is Japan, which have actually taken the toll from those who are working, and 40% of their taxations go into healthcare. So talking about 2030 UHC, I think it is still going to take a longer time. Coverage of insurances, yes, but at the same time, there are lots of challenges that we are facing at the moment. Right from the cost of service to the quality and coverage. So all this thing is coming up in this as to how we can take care of it. Still, people are paying out of pocket. Still, there are some private insurances which are also thriving over there. So this coverage, I feel, will take a time.
Well, thank you for that. But yeah, I'm coming to you because mine is actually talking about investments. You register the private hospitals in Tanzania. No, you'll add. Also, when I'm also asking you the question, all these private hospitals, and we've seen the gaps. The gaps is in specialist care. That's what people want to go to. They want to go for dermatology. They want to go for more advanced treatments. Is why people are leaving. How can there be a more supportive infrastructure for the private health sector? Think Tanzania, think region, to be encouraged to invest more so that we can keep people here. Because I think the issue is sometimes about money and investment.
Let me answer this.
Yes.
The most important thing is the finance. Historically, and 80%, my registrar is sitting over here, will correct me if I'm wrong, 80% of the structures of private health sectors are converted apartments, converted buildings into hospital to suit the thing. Okay? We have still not achieved in private sector to reach that purpose-built hospitals be there. And the reason for this is finance. How do we work out the finance? How can we address that issue of finance, or how can we be recognized? If you go to the banks, they do not recognize you as a real investor into health system. So this is where the catch is. So the biggest problem of poor infrastructure or compromised infrastructure in healthcare in private is finance.
Thank you very much. I think Dr. Habu has spoken some of the part of it, but I think if you take the contribution of private sectors in the country, actually it is contributing 44.1% in the health sector. The government has taken a big accurate support to the, especially at the zonal level. For instance, we have got Bugando Medical Center. The government has supported it now is offering cancer services along the northern zones. And also it has supported KCMC, which is also a private facilities. It has invested a lot of money. In Bugando also it has invested a lot of money. Actually, they are offering tertiary services, which is also, actually they are trying to distribute the specialized services according to the zones. So in the northern zone, it has taken KCMC. In the lake zone, it has taken Bugando Medical Center. Also along the western zone, for instance, we have Good Samaritan, which is also a specialized cancer hospital. It's a private, it's being supported by the government. Even Aga Khan, some of the waves actually are being, some of the, in the indirect, actually there is a big wave that is offering. So the government actually has taken a good investments among the big facilities that is supported, actually private facilities. And it is planning actually to, for instance, now we have got KCMC and Bugando currently. Yes. And yes, most of them actually the government is supporting, and the FBOs, most of them. But apart from what we said of the universal health coverage, the government actually initially, there were very few people who were actually being supported by the insurance companies. But later on, it came to realize that most people cannot be able to cannot afford services, especially specialized services. So what the government did, it is going to contribute to the people who are not able to pay so that they can get that ID. Wherever they go for service, they can be treated. That is the system. Actually, currently it is on the parliament. It is on the ongoing motions. It will be effective soon. It will be a reality.
But tell me very quickly. Private sector, you talk a lot about governments. Private sector needs to accelerate medical tourism in the region. What really needs to be done from a private sector perspective?
Okay.
In a big way, because we're not doing it in a big way.
Okay, the motion of medical tourism in the country, it came the way back. Actually, they went back to the data since I think they went from 2009 and 10 to 2020. They reviewed the cases that are being referred abroad. The cases that were identified actually were cancer, liver transplant, renal transplant, stem cell transplant, and actually cochlear transplant. What they did, the government did, actually included the private sector in offering those services. That's what I'm saying. For instance, in the northern zone, the government supported the KCMC to provide in medical tourism, actually cancer services. And they supported Bugando, also it is providing cancer services. And it is still on the verge of supporting even Aga Khan. They are going to start soon implementing cancer services. So the government in the actually it has got an agenda of including private and public sectors in reaching the goal of providing medical tourism in the country.
Okay, thank you.
And unfortunately, when they are mentioned in Tanzania, was not mentioned, but it has advanced in medical tourism.
Okay.
Sometimes I think we can share even the figure.
Okay, thank you. Dr. Shakur from Ethiopia. I'm always impressed by the number of medical students who graduate from Ethiopia. In fact, I even think that they only teach medicine in Ethiopia. I don't know whether that is true, but you have huge numbers. And before I lead to that, with those numbers and your private sector is still very young, what do you see greater collaboration with Ethiopia in terms of this medical tourism? Instead of us flying to Ethiopia and trying to market our destinations, are you not able to give us something as well?
Yeah, thank you.
In a bigger collaborative way, not in a Kenyan selfish manner or Ugandan or Rwanda or whatever it is. Yeah.
Thank you very much. You see, just some 20 or 15 years back, we had only 2 medical schools. Now we have reached almost 40 medical schools, 40 medical schools. They are graduating almost 3,000 medical students a year. And as you remember, just 15 years back, we were having 2 or 3 small clinics in Addis Ababa. Now, there was a time it was prohibited to practice privately. Now, almost 40% of the health coverage is done by the private sector. In Addis, we do have specialty hospitals nowadays, good model hospitals, tertiary services given. There is a great change in the service. As you know, most of our professionals, they go abroad after staying for some years. With a good experience, they have started to return back and invest in Ethiopia. So it seems good. The time looks good. The future holds good for Ethiopia. And the only problem that the financial issue. Actually, there is, as it's said by the other colleagues, there is no bank facilities to give you collateral unless otherwise you have brought collateral. They don't take your institution as a collateral, small business. Or lease system, there is no lease system. The government is searching a way out of this, and they are involving us in medical tourism also. Our people go, most of them go to Thailand, India, and some to Dubai. Even for small, trivial, minor problems, they go. Those who afford, they go to these countries and they spend a lot. Now, during the era of COVID, they have experienced that COVID gave us good chance. There was no transportation. They stayed home. It was a blessing under disgust. So they came to most of them, they came to understand they can be treated in the countryside. Most of the people go abroad, not only for the clinical excellence, for the non-clinical part also. The hospitality, the nursing service, and the administrative service, they make some look for abroad. So we came to understand we have to work hard in holding these people to our country. Some people also come from neighboring countries, like, as it's said, from Somalia, Somaliland, from South Sudan, especially from Eritrea. Patients are starting to come to Addis, are getting service. Now, I think the future holds good for East Africa. If we intensify our collaboration and working together, we can save our people from going abroad and suffering, spending a lot. Thank you.
And you don't see yourselves because of money issues. Kenya pays very well. You don't send your doctors to work here. They speak English.
Yes, our patients are coming to Kenya, and some university lecturers are helping us in Addis in explaining even in the center of the city, there is a big poster showing that advertising Kenyan hospitals, especially PET scan service, and cancer chemotherapy as it's given in Kenya. So we are having good ties with Kenya. So
I want you to let Ethiopian doctors work in Kenya. They only work in, we have Egyptian doctors working at the Coptic hospital.
we have few
But I think if
friends
you have
here.
more Kenyans, because you're not,
Yes,
we can
yes,
pay
yes.
better than Ethiopians.
Yes, we have few physicians here working here. Actually, they
50.
pass through here to Botswana and African countries and Uganda. They pass through Kenya. I don't know why they are not sticking in Kenya. Maybe the administrative issue.
Yeah. It's some of the things which was alluded, which this panel may not have a chance to discuss, is are we operating a closed shop in our countries where we don't allow foreign doctors to practice? If they practice here, they would improve our skills and they would live and we would be better off, quicker and faster. But it's a food for thought, no need to respond. Dr. Pradhan, because of time, what would be your last words to this panel, to everybody? Or would you want to pick up anything that anybody has said?
So, wanted to touch upon this investment issue. What India did was a couple of years back, they realized actually doctors are the money bank. All of us do know who gets the highly paid, whether it's salaries, whether it is consulting fee, doctors are the rich in any country of the world. So they said, why don't we invite our doctors who are working outside in all other countries to come back and set up hospitals? So what they did is something called one window approval. You come, no hassles, hassle-free approval for your hospital. And that improved the number of hospitals. A lot of doctors who are having a lot of money in US, UK, Canada, Australia, they came back to set up the hospitals. So that's one financing issue, investment issue can be sorted out. Looking at that, a lot of investors developed confidence. Okay, these doctors who are practicing abroad have come back to India. Let us invest on them. So that is how the whole investment issue got. It's not government. All of us are poor countries. Correct. India is no less. So we have also grown from a very poor kind of a country. But these are the tricks and techniques or strategies which countries need to apply than waiting for some money to kind of land from heaven. It will never happen.
Thank you. Dr. Shakur, you can go now. Your last words for the panel or thoughts?
Well, the transforming knowledge is very important. The advertising is also very important. The other is the visa issue, the common currency issue in the Africa, especially in East Africa, has to be done and seen throughout in the future to develop this inter-IGAD or inter-East African communication and in business and medical tourism. Thank you.
And travel. Thank you. Dr. Mwanisi, any last thoughts or anything you want to pick up from the discussion?
Thank you. I think there are issues that we need to consider when we are dealing with this medical tourism. We have also to try to create a sort of conducive environment. We talked of the issue of investment incentives. Like actually, our bank should consider the issue of providing at least a soft loan, which will help them at least to develop at the level that they need. Also, we need also to tax relief. We need to consider the issue of tax relief. Also, we have friendly human resource policies. For instance, sometimes for the one that you have mentioned, some people are working outside. Or actually, even foreigners want to come to work in our country, we have to make a policy that will facilitate them to come to work in our country. And in so doing, actually, where we are going to improve the issue of human resource. Also, there are issues of improvement of transport and the related infrastructure. We have to upgrade our airports. For instance, making patients wing. Also, we have to reduce traffic jam, make special arrangements for the ambulance if the patient has arrived at the airport, who can they can be filled easily at the facility and where. But there is a big issues that we are forgetting whenever we are talking of these issues. We can improve, we can have the best qualified health personnel, We can have superb infrastructures and whatever that we have, even the cost. But if we forget the issue of customer care, that will fail a lot of people. So we need to improve the issue of customer care. How best you can be, but if you don't have customer care, actually our clients will run away from us. Thank you.
Thank you. Thank you.
I would put my efforts on recognizing the regions. For instance, I do not know what Kenya is doing. Kenya doesn't know what Tanzania is doing in the field of medicine. We do not know what Rwanda is doing. So it is important that certain initiatives to be taken at the level of associations to cross-border the professionals to actually come and conduct certain camps, they show the procedures and all this. This is how India started. This is how India started. A couple of guys used to come from India when they were not getting business. Sorry for this, okay? But when they were not really thriving, they decided that let us go out of the country and advertise ourselves. And that's how the professionals came in. They talked about it. Then we gained confidence that there is a gentleman who can do these procedures, who has done it in Dar es Salaam, and so I can refer him. So that sort of a trust and understanding, if we can develop among professionals through the associations, the professional associations and federations, I think we will reach somewhere. Thank you.
Yeah, thank you. Danny, last words.
Thank you. Actually, was wanting to say the same. I wanted to say the same thing, and just want to echo on what he has said. I think learning from what others have done, but also using the existing platform, for shared best practices. It's very, very key, and really stop that fear from the neighbor, from the other, leveraging from, for instance, the existing human resource. I don't know whether you know that Rwanda is organizing CHOGM, the Common Health Heads of State meeting, and you had a team of delegation from Rwanda who came to scout Kenyans here, for actually customer care, among other things. But we have Kenyans who come and train, Rwandans in different areas, including in the healthcare. So we really have to leverage on what we have here, take advantage of what India is doing and what they're doing, and they're really eager to share the experience and then build it locally, build it for the region.
Thank you. Ladies and gentlemen, can you just give an applause for the panel before I close? Well, I think speaking as your moderator and listening, and I hope the audience have appreciated it, is that speaking from you from diverse regions is that we need to really look at so many different aspects to stop making medical tourism in East Africa a buzzword. We're a huge population, 300 million, many people are poor, but we're doing things differently, so government involvement in what we're thinking is critical. Policies need to be developed. We need to look at our human resource. And not only that, we need to have a plan for it. And also have a plan for medical tourism with targets and things that we can measure. Because if we just talk about it, our elite will keep going abroad because there's a sense of entitlement. The poor will continue dying, not receiving the care they need. And the world is evolving, and I think COVID, as we have mentioned, has changed all our perspectives. If you can't leave, then you must get treated here. Are we ready to treat? That's a question we're saying. And from the panels, you're saying East Africa is ready. You need money for the private sector, for investment. You need to attract the human. We've got an expert. He can help us. How do we bring the needed labor? And coming very clearly, the infrastructure is not only buildings, hospitals, but do we have people who can deliver the service end to end? From the time the person says, I'm coming from Chad and I want to land in wherever, are you able to pick whatever, take the person to hospital, return them, in a better condition than they were, seamlessly without hitches and everything. So I think we have a lot cut out from us that's coming up, and I'm sure more will come in the next sessions. Thank you very much for listening to us, and thank you, Santi.
So thank you so much. A round of applause, ladies and gentlemen. So and at this point, I'd like to direct you to where we'll have a short branch where they'll have the exhibition booths on the left. There's a place you'll have a short meal. Then we'll come back in the next 25 minutes. So we'll start this next session at exactly 2, which will be the panels for the medical tourism. So kindly proceed towards this side, towards the meal, and please pass by the booths. Have a look at the exhibition booths, look around and enjoy. Have a good brunch.